Okay, everybody, thanks for coming to the Interdisciplinary Targeted Learning Session number 5. Presenting today is Dr. Tyler Stackowitz on pulmonary embolism. Dr. Stackowitz is a full-time urgent care physician at the Victoria Hospital Urgent Care. He's a family medicine trained with +1 in ER, and I'm sure that he'll give you some more interesting tidbits about himself. So we'll have the presentation that Dr. Stackowitz has prepared for our educational learning, and then we'll have a question and answer session at the end. So feel free at the end to raise your hand, and we'll go through everybody that has questions. And just so everybody's aware, because we have some members that would appreciate having the lecture viewable afterwards, it's being recorded, just so you know. Okay, but it's not going to be distributed en masse, only on request to certain individuals in our group. So Tyler, go ahead.
All right. Okay, so first thing I'm going to do is I'm going to turn my camera off, just so that you're not distracted by my new haircut. As soon as I figure out how to do that. There we go. Perfect. Okay, so let's get going here. So like Chris said, my name is Tyler Stackowitz. I'm a CCFP EM trained physician working at Victoria Hospital. I've been a practicing attending for 10 years, and today we're going to talk about pulmonary embolisms. So I like PE because I think it represents a diagnostic dilemma that we see a lot in potentially dangerous emergency diagnoses, where we're balancing over-testing with good management and appropriate workup. I can remember in second year medical school, we had a lecturer come in and tell us that if you're a patient and you have a brain tumor, you want to see a neurosurgeon. If you're having a STEMI, you want to see an interventional cardiologist. And if you're having an appendicitis, you want to see a general surgeon. But if you're having a headache, chest pain, or abdominal pain, you want to see an ER doctor. Because that's the basic essence of our job, is to take undifferentiated complaints and presentations and turn them into some kind of diagnosis to either rule out or get people on the right path to getting the care they need, whether that's with a discharge or just a referral. So full disclosure for this talk, okay, in my last year of residency, I actually did a research project on PE management in our department, where I kind of audited the charts to see if the attendings and the residents were following the best practice guidelines for managing PE, and then kind of flip that into a grand rounds presentation on the topic in general. So this is a recycled talk. I have updated it. I put some more recent guidelines in here. And because most of the people here today are practicing clinicians, I sort of skewed it a little bit further away from pathophysiology, which I'm sure we're all familiar with, and leaned it more towards the diagnostics and evaluation component, which I think is where the real nuance of this diagnosis comes from, and where I think a lot of people get tripped up doing things they shouldn't. So these are my children. That's my daughter Zoe on the left and my son Max on the right. And this is what they look like when I gave this talk the first time. And this is what they look like right now. So a little bit of time has passed, but hopefully I'll also change the background too. So this is basically like a brand new talk. So we're going to talk about causes briefly. Okay, like I said, a little bit about physiology. And then the bulk of the talk is going to be centered around risk factors, kind of history and physical stuff, what's important, what isn't, and then diagnostics. So how do we nail it down, who gets what? Treatment and prognosis is going to be a smaller part. Okay, so I'm going to apologize to the pharmacists in advance. We're not really going to talk about specific drugs or drug dosing or all that kind of fancy stuff that you guys like, just sort of a general overview of treatment. Because the reality is most of us work with pharmacists, and if you have a question about treating a PE with drugs, you can always look it up or ask the pharmacist, which is what I do. Okay, let's talk causes. So basically, you either get the clot that originates in the lungs or starts somewhere else and then migrates towards the lungs. Okay, there's different types of embolism. So in this talk today, basically, we're just going to focus on the blood clotting kind. Okay, there's different ways you can get different stuff into the lungs. And honestly, all these things, there's not a whole lot you can do about any of them. It's just supportive care. You cross your fingers and you hope. But the blood stuff, we can do a little bit more about that. So physiology, sure, we're all familiar with Virchow's triad here. Sorry. So stasis, which is abnormal flow, hypercoagulability, endothelial injury, can all lead to developing clots. Okay, this is an obstructive shock. So when someone comes in with a PE, The mechanism of what's happening is obstructive. So you can get heart failure and a cardiogenic component if the PE is severe enough, but usually that happens, 12 to 48 hours into the diagnosis or into the disease process. So initially what you're seeing is an obstructive problem. So that right ventricle just can't push through, all right? So your pulmonary vascular resistance goes up, both because there's a clot in there causing the problems, and also because that hypoxia causes vasoconstriction within the pulmonary vasculature. Your RV afterload goes way up. So remember that right ventricle is not used to pushing against a lot of pressure. So when there's something obstructing it, it tends to dilate, it tends to be unhappy, okay? Gas exchange, this is a dead space problem, okay, not a shunt problem. So the lungs are working just fine. There's gas everywhere, oxygen-rich air that's in those lungs. It's just there's no blood going there to get it to take it to the rest of the body. You get hypoxemic. Remember, there's a good chunk of the population that still has a patent foramen ovale, so that little gateway between the right and left atria. So in a normal working heart, it doesn't really matter because the left pressure is so much higher, but when that right pressure goes up, you get unoxygenated blood coming from the right side of the heart, going to the left side of the heart, bypassing the lungs. So all the supplemental oxygen in the world doesn't really help with that problem. So classifications, just briefly, so massive, submassive, and low risk. Remember, this has nothing to do with the size or the location of the pulmonary embolism. It just has to do with its effect on the person. So massive PE is defined as someone with hypotension, so systolic less than 90 for more than 15 minutes, or someone who needs vasopressor support to maintain a pressure over 90, okay? Submassive is anyone with a PE that's got signs of RV strain, either on ultrasound or on CT, or someone with signs of myocardial necrosis, so someone with a high troponin, right? And then everyone else is low risk. So if you got a PE and your vitals are fine and your heart is fine, then you're a low risk, and that's how we kind of differentiate. And that gets more important as we move into treatment, which will be a little bit later on in the talk here. All right, why is PE important? So 1 per 1,500 is kind of the general rough consensus of incidence of PE in the general population. Okay, third highest cardiovascular disease mortality, obviously behind heart attacks and strokes. If you look at mortality, there's lots of papers that quote high mortalities for PE, and these are all from registry studies that look at PE diagnosis for admitted patients. Okay, so that mortality 15 seems high. It actually is high, and we'll talk a little bit more about why that's a little bit misleading in a couple of slides. So most common reversible risk factors for PE. So on history, obesity, hypertension, and smoking are kind of the big ones. And the HR there stands for hazard ratio, which is how you multiply the incidence going forward. So if your risk of getting a PE is 1 in 1,500, if you're obese with a BMI of over 35, your risk is 2 in 1,500. So these aren't, big land movers as far as risk, but they are there, and every little bit adds up. Obviously, there's other risks there. Okay, the big one that we worry about, especially in young women, is the oral contraceptive pills, the hormone pills. Okay, that incidence is there. I mean, it's real. It does increase your risk, but it is still rare. I think the last time I looked, the FDA said that oral contraceptive pills cause between 3 and 9 clots per 10,000 people or 10,000 women on those pills, assuming everything else is healthy, right? And just for context, their risk of getting a clot when they're pregnant or postpartum is actually higher than their risk when they're on oral contraceptives. So I want you to bear that in mind next time you see a 20-year-old with undifferentiated chest pain that's on birth control pills. Okay, it's not a death sentence for a PE. Okay, it's still much more likely that they don't have that. All right, plane rides. Okay, so we've all heard the long period of immobility. I had a long car ride. I had a long plane ride. Does that actually increase my chances of getting a clot? And the answer is kind of. Okay. So 27 PEs per million patients within 14 days of any trip greater than 6 hours. Okay, so that's kind of the keys here. So what they found was if you were prolongedly immobile on a plane ride for less than 6 hours, that didn't appreciably change your risk of getting a PE or a DVT. Okay, so anyone that's taking a flight anywhere in North America, the guy that flew from Vancouver to Winnipeg is not getting a DVT or a PE from that immobility itself. Okay, so obviously the more other risk factors you have to predispose you for a clot, the more likely you are to get a clot from that trip. But 6 hours is kind of the magic number, and it's still very, very low, right? You can see those percentages there. The vast majority of people that fly across the Atlantic Ocean do not get PEs and DVTs. So again, it's a risk, but it's a small one, and only if the trip is long enough. Okay, so let's talk about that mortality section there. So 15% seems very, very high, okay? So this was one of the studies in the Lancet that kind of quoted that number. And basically they're just looking at consecutive patients with PE, but these were very sick patients, cancer patients, and the all-cause mortality was there. So basically if you had a PE and you died, didn't really matter what you died of. If you had a PE, they put you in that 15% mortality. So another study here, kind of looking, this one's a little bit more real world applicable. Okay, so the bottom line with PE is if you come in with a pulmonary embolism, so the ambulance brings you in and you're in cardiac arrest, okay, so they're doing CPR on you, then you have a 95% chance of dying from that PE. If you have CPR within 24 hours, so again, cardiac arrest from a PE within 24 hours of your visit, your chance of dying is 77%. And if you get thrombolytics for your PE, your chance of dying is about 30%. Okay. But then they go on to say that if you have a PE, but you're stable enough and live long enough to get a CT scan to actually diagnose it, your mortality is 2%. And if you get a VQ scan, your risk is 1%. Okay. So like the vast majority of PEs that you're going to diagnose are going to be in that lower set. So just because you diagnose someone with a PE doesn't mean they have a 15% chance of dying. Okay. Sick people with PEs that have physiologic compromise from their PE have about a 15% mortality in all comers. So that number again is a little bit misleading. So PE is dangerous, but not, super dangerous when you look at the broad category of all the PEs. Okay, let's talk about DVT. So this sort of had some popularity there. Can you use an ultrasound to rule out a PE? So do PEs and DVTs kind of go together? So this study looked at, consecutive retrospective patients and found that there was not really a great correlation between PE and DVT. Okay, so if you had a DVT, you didn't necessarily have a PE and vice versa. So their conclusion was that there was no real association between the two disorders. Okay, so if you think someone's got we'll get into this later, but if you think someone's got a PE and you think you can just ultrasound their legs and if they're clear, then you're good, you can't really do that. However, this was kind of an interesting study where they did lung scans in people with PEs who had no symptoms just to look and see if there was stuff there. And they did find that between 40 to 50% of people with DVTs did have a silent PE there. So, I mean, for me, this is just evidence for treating a DVT, because if you have a DVT, it's more than likely is going to progress to a PE. You're going to have some problems. So this is why we treat DVTs with the anticoagulation. So this is evidence for treating DVTs, not for ruling out PEs. Okay, so this is where if we were in like an actual lecture hall and, I could point at people and pick on them, I would do that, but I'll just let you give that a read here. So we're getting more into the history and physical of what we do with PEs here. So this is a study, and we'll talk about this on the next slide here, looking at what do you think the most common complaint of a person presenting with PE is? So drum roll, and there's your answer. Okay, it's actually dyspnea. So there was a study done, it's called the PILPED, which stands for Prospective Investigation of Pulmonary Embolism Diagnosis. And what they did is they looked at a whole cohort of patients, some with PE and some without, and kind of compared their findings on history and physical exam. Okay, so people with PE, these were the numbers. So you look at the common symptoms you might see with that, hemoptysis, sort of chest pain, right? Signs or symptoms of DVT on the bottom. And those percentages there are, what I find more surprising is what's not there, right? So 36%, right? So that means that 64% of people did not have dyspnea, right? Over 50% of people do not have pleuritic chest pain. Most people do not have signs of DVT, which is not super encouraging. And if you look at the without numbers, right, the calf stuff is a little bit less, right? The chest pain's a little bit more. The dyspnea is kind of equal. So this is not super helpful as far as the history is concerned. So what about physical exam stuff? So same thing. So with PE, look at those numbers there. So most people, right, don't really have that one key sign there. And if we look at the with PEs, those numbers again are pretty similar, all right? So P2 heart sound there, I put that in there because it was in the study. Okay, nobody's going to hear a P2 heart sound unless you're a cardiologist who's old school, who listens to like thousands of hearts every day, right? That's the physiologic splitting of that S2 sound where the pulmonic valve and the aortic valve kind of make separate noises. As that RV pressure goes up, that pulmonic valve snaps closed a little harder and you can hear it. But again, like you're not going to use that to make a diagnosis. And again, it only happens like 15% of the time anyway, okay? So what about reproducible chest pain, right? That's always a favorite with chest pain. Someone's got chest pain, but you can push on it and make it worse, or move their arm and make it worse. Surely that can't be a PE, but that wasn't really found to be brought out in these either, right? So just because you've got reproducible chest pain doesn't mean that you're not having a PE, and your respiratory exam is basically next to useless, I mean, not for excluding other things, but if you're relying on your physical exam findings to clinch the diagnosis for PE, then, you're not going to be able to do that. So why am I giving you all this depressive news? Well, it's because I don't want you to be too overconfident when you're going to see people with PE. Recognize that PE is a challenging diagnosis, and we need more than a history and physical to try to sort out who's going to get treated with what. Okay, so PE is not a clinical diagnosis. Okay, there's no constellation of physical exam findings or history information that's going to cinch that for you. All right. So we need to come up with a way to figure out how we're going to decide who gets worked up for PE and who doesn't, okay? Because you can't scan everybody, right? You can't just prophylactically anticoagulate everybody. So we need to have a way of ruling in and ruling out the disease in a reasonable manner so we're not missing too many cases, okay? So likelihood's important, and we have tools for that, okay? So there's different scoring systems, decision rules that have been externally validated that are very useful for helping, but you have to use them in the right way. Okay, so this is not, I think someone has a PE, I'm just going to use Wells, or I'm going to use Geneva and it's going to tell me what to do, because it's not that simple. And if you start applying these rules to everyone, if you start applying them to patients that are not appropriate, then you run into problems. Okay, so Gestalt is important. We're going to talk a little bit about this in a second here. Okay. I don't know if you know what Gestalt means or not. So I put the Webster's definition here for you so you can read it, right? Basically, it's what you think is going on, okay? So in the 1970s, they developed this lab test called the D-dimer, okay? And they used it mostly to try to diagnose people who are suffering from DIC. And then in the 80s, some smart doctors decided that, hey, you know what, there's other diseases where people have clots that might be useful if we had a test that could rule that out, specifically DVTs and PEs. And in the early 90s is when kind of the modern ELISA D-dimer test was born, kind of was FDA approved, and then became more mainstream in all the emergency departments. So all these hospitals had this great test, and that was the thinking. We're not sure who's got a PE, we're not sure who's got a DVT. We're just going to do this D-dimer, and it's going to tell us who's got clots and who doesn't get clots. And what we noticed was in the 10 years after D-dimer testing became mainstream, the diagnosis of pulmonary embolism went through the roof. So you look at the 10 years after D-dimer and the 10 years before D-dimer, they were diagnosing way more PEs. So that diagnosis number went up, but what they found was the mortality stayed the same. So we were diagnosing way more PEs, we were treating way more people, but we weren't really having an effect on mortality. So like, what's going on here? We're wasting all these resources, doing all these things, and we're not saving anybody. So what's the point? So then some other smart doctors got together and started doing some research and said, how can we fine tune this a little bit so that we're not just, throwing radiation and anticoagulants at everybody? So CUSA researchers. So Jeff Klein is a big pulmonary embolism research guy, and he came up with this PERC rule. Now, I like the PERC rule. Okay, it's PERC stands for pulmonary embolism rule out criteria. Now, this is a 9-component scoring system that you can use to sort of, discount PE kind of at the get-go. Okay, so these are the things. This rule is only applicable for patients where you think it's possible they might have a PE, but you think it's very unlikely. Okay, I'm going to say that again. This is not for people who you don't even think it's a possibility. It's not for someone who you're worried has a PE. It's for someone where you think it's possible, but you think it's unlikely. Okay, now they did a study where they looked at 500 emergency physicians and sort of asked them for a variety of patient complaints. Do you think this person has a PE? Yes or no? And just based on the physician's, assessment and what they thought, any patient that they put into a low probability category. Okay, so if they said this group of patients, we think it's very unlikely that they have a PE, the incidence of PE in that group was about 3%. Okay, now that sounds good, but in medicine, the magic number is 2%. Okay, so if you can get your diagnostic probability under 2%, then that's considered an acceptable miss rate. Okay, that's what they use for MI diagnosis. That's what they use for, API diagnosis. That's the gold standard there. If whatever your pretest probability is, if it's less than 2%, then you're good. Okay, so with this PERC rule, if you apply it to patients with low probability PE, so you think this is a low probability and they're PERC negative, then their chance of PE is less than 1%. Okay, so you're good, you're done. Okay, a PE risk of less than 1% is the exact same risk as someone who has a negative CT-PE study. All right, so if you get a CT scan and the radiologist says, nope, there's no PE, if that's good enough for you, then this in a low risk person should be good enough for you also. Now, this is an all or nothing thing. Okay, calf symmetry on this means you lift up the legs, you look at them. You don't measure them. There's nothing fancy. Do they look asymmetric to you? Yes or no? All right. The heart rate is at any point during the visit. So if their heart rate's 105 at triage and then it's 95 when you see them, that doesn't count. Okay, they don't perk out. So all this stuff has to be negative in a low risk person, and then you're done. Okay. All right. So I say low clinical suspicion. Well, what does that mean? Okay. So I'm going to let you read this vignette. Okay. And then I will tell you that this person is PERC negative. All right. So you read this and you tell me if you think this lady is low risk for PE or not. So if you see someone and you're worried that they might have a PE, don't use the PERC. Okay. That's not your get out of jail free card for everyone. Okay. Same in that you shouldn't be using it on people who you don't even think has a PE. Right. So some 25-year-old girl that sprained her ankle that's very upset, whose heart rate is 104, she's PERC positive, but you wouldn't CT her, right? Because that would be ridiculous. So it's got to be people, like I said, low risk, where you think it's possible. All right, let's talk about Wells here. So Wells score for PE. So once you have a patient, okay, who you think could have a PE, you think it's low risk, but it's definitely possible. You try to apply the PERC rule, but it's positive, so you can't clear them with that. Now you need to do something else. So you need to do something that's going to take that probability either under 2%, or you're going to have to do some more testing. So with this scoring system here, notice the second line there, all right? Alternative diagnosis less likely than PE. That's a super important part to all of these decision rules, okay? What you think matters. Do you think the PE is the most likely diagnosis, or is it number 2 or 3 down and you're just trying to rule it out for posterity there? Okay, so add these points up. Modified Wells score. Okay, the original Wells score had a 3-tiered result, right? So low, intermediate, and high risk, right? But your decision for this afterwards, there's only 2 possibilities, right? You're going to apply this Wells score, and then you're either going to scan someone to look for a PE or you're not. So if you only have 2 possible decisions, it doesn't make sense to have a rule that gives you 3 possible outcomes, right? So with this scoring system, add the numbers up there, okay? Now, if you are PE unlikely, okay, so their score is less than or equal to 4, that gives you a risk of PE of about 3%, okay? Now, 3% is good, but it's not under the 2, that's our magic number. PE likely, so if you're over 4, that carries a risk of about 28%. Okay, so what do we do next? So let's talk about D-dimers. Okay, so I gave you a little bit of history of the D-dimer there, right? So D-dimer is looking for clot breakdown, but how good is it in looking at suspected PEs? Okay, so 90% sensitive in acute PE, right? Now that's 90 is good, but 90 is not 100. So if you're a high-risk patient, okay, like Wells likely, and your risk is 28%, a negative D-dimer does not, okay, I'll say that again, does not exclude PE, all right? So if the radiologist is giving you crap about scanning someone with a negative D-dimer, right, you can quote this study or tell them to phone me and we'll explain to them how D-dimers work, all right? So 90% sensitive, which means that it's not good enough to just do the D-dimer in a high-risk patient. Specificity, okay, 37.5. That sucks. Okay, what that means is that 62.5% of people without a PE are going to have a positive D-dimer, which is a huge number, which is why you can't be doing D-dimers on everybody, because if you do a D-dimer on everyone that hits your door in the emergency department, you're going to get lots of positives, and then you're going to be stuck not knowing what to do with those. Okay, so if we apply D-dimer with the modified wells there, okay, so PE unlikely, remember that was our 3%, with a negative D-dimer takes it down under 1. So now you're good, right? So I have a low-risk patient who's got a negative D-dimer, and that takes me well under the 2%, and I'm done. So remember, that PE unlikely with negative D-dimer, less than 1%, that's just as good as someone with a negative CT-PE study, okay? PE likely, right? So those people over 4, that 28%, even if the D-dimer is negative, that still carries a risk over 3% of having a PE, which is not at the 2%, right? So it's low likelihood, right? Chances are when you scan that patient, they're going to come back without a PE, but there's no other option for those patients. Okay, if they're high risk, you got to scan them. There's no way around it. Don't even do the D-dimer. It's a waste of time. Positive, negative doesn't change your management. So obviously there's lots of factors that can affect your D-dimer, okay, which is why the test is not super specific. Okay, there's no real point in getting much in depth into those. Another popular thought was that maybe, hey, we can use EVGs to see if someone's got a PE, right? So the reason you get an arterial blood gas is because then you can use the arterial oxygenation and the alveolar oxygenation, calculate your AA gradient with some fancy math, which sounds good, except when they studied it, they found that between 10 to 12% of patients with PEs had a normal AA gradient. So you can't really use that. All right. Now with D-dimers, it boils down to this one conceptual question, right? And I tell all of my residents and all of my students this, okay? If you order a D-dimer and the lab calls you and says, hey, our D-dimer machine is broken, we can't do any D-dimers today, what would you do? And if the answer is, I wouldn't do anything, I would just send the patient home, then you shouldn't have ordered the D-dimer in the first place, okay? If the lab calls you and says, hey, the D-dimer machine is broken, then your response should be, okay, I'm going to have to scan the patient. If you're waiting for a D-dimer, sweating bullets with your fingers crossed, hoping to God that it's negative, then you shouldn't have ordered that test, okay? Because you don't believe that patient has a PE and you put them in the wrong category, all right? When that D-dimer comes back negative, what that's doing is that's talking you out of doing a CT scan, right? So your D-dimer is either positive, which is great, it's more ammunition to get my CT in someone that I think has a PE, or it's negative, great, I don't have to do the CT, let's move on to the next thing, okay? So you really got to use it properly. A D-dimer is a scalpel, all right? You got to use it for precision decision. That rhymes, I didn't do that on purpose. It's not a machete, okay? If you're using your D-dimer like a machete, you're going to make a mess. You're going to get a bunch of lab values you don't know what to do with. You're going to scan too many people. You're going to anticoagulate too many people, and it's going to cause problems, okay? So use the decision instruments properly, use your gestalt, put those people in the category they need to be in, do the test that they need, get that probability where it needs to be, and then make your decisions, okay? All right, question 2. This will be more picking on people here. So this is probably not really a fair question. I'll let you have a quick look here. So technically speaking, the gold standard is pulmonary angiography, okay, but nobody does that. And studies looking at imaging found that CT angio, even the old like 16 slice scanners, were just as good as pulmonary angiography in diagnosing PEs. Okay, so let's talk about VQ scans. So people like VQ scans. It's kind of this mythical test that you can use that doesn't expose people to radiation and yada, yada, yada. And it's kind of a useless test, okay? A VQ scan for PE is kind of like getting an ultrasound for an appy, right? Like 90% of the time, you're going to get a result that's uninterpretable and you're, no further ahead than where you were before. So when you get a PE, first of all, you got to have a normal chest x-ray. So anyone with any kind of respiratory pathology is out. And you got to have, everything light up the way it's supposed to. So for the VQ scans, if you have normal perfusion, normal ventilation, right, that's great. That completely excludes a PE, you're done, right? If you have a picture like this on the bottom where you got perfusion defects with normal ventilation, then that's diagnostic for a PE. So great, you're done. But the problem is there's this big section in the middle, right, where low and intermediate probability scans where you get perfusion defects that either don't match or you get perfusion defects with lung parenchymal abnormalities. And both of those results are essentially non-diagnostic, okay? So if the nuke med guy calls you and says, yeah, we got an intermediate scan or a low probability scan, you can't really use that to help you make your decision. And the radiation thing is interesting also. So it's true that you don't get as much radiation, right? So it's kind of, 6 of one, half dozen of another. You get a woman who you're worried about a PE and, she's pregnant. So you can do the CT, which probably isn't going to do a whole lot to the baby, but does increase her risk of breast cancer. Or you give her a VQ scan where her bladder fills up with radioactive isotopes, and then her kid has an increased risk of cancer early in its life, right? So there's no perfect test. To say that a VQ is harmless is not true. So, I would put VQ in the same realm as CTPE studies, okay? Do the test if you have to, right? But don't be overusing those things. Okay, so PE studies. So this was just comparing, angiography to CT, right? So is it really as good? And the answer is yes, right? So 23 studies, over 4,600 patients. So people that had a negative result, okay, so radiology reads the CT, it's negative. They followed those people for 90 days and found that 1.2 of them developed a PE going forward. Now, I don't have the data to say when they developed those clots, right? My guess is they were probably closer to the end of that time period. So if you have a CT that's normal and then 2 days later you're dying of a PE, then yeah, that's a miss, right? But if you have a negative CT and 2.5 months later you get a PE, I mean, is that a miss or is that a PE that just showed up in that time period, right? But the bottom line is that those results were, very similar to pulmonary angiography. I don't even know if you can get pulmonary angiography. The radiologist might laugh at you if you ask for that test going forward. So just do the CT. It's just as good. Any scanner will work. As long as it's a real scanner and there's an actual radiologist, it's just as good. Okay, I put this on here just for fun, okay? So magnetic resonance angiography, this is a real test, okay? This is another one, you'll probably get yelled at if you ask for this test. It can be done, right? So you kind of avoid the radiation there, but MRIs are technically challenging, okay? You have to lay still for a long time. Motion artifact is horrible in disrupting the radiologist's ability to read the scan. So when they do this, they find that about 25% of the time they get unusable images, okay? Because it's really hard for the person to lay still and regulate their breathing for, the 20 to 25 minutes it takes to do this, okay? So it's there. Technically, you could do it, but I don't ever see a reason why you need to do this. Okay, let's keep going here. So looking at VQ scans versus CTs for outcomes, okay, so they found that there's no difference, but remember that first slide I showed you, or one of the first slides I showed you, if you have a PE and you live long enough to have your CT or your VQ, your mortality is pretty low anyway, right? So 98 to 99% of the people are not going to die with their PE if they have one of these tests anyway. So the reason you're not seeing any statistically significant difference is because the outcomes are so overwhelmingly favorable, right? So, I mean, do whatever test you want, right? Know the CT is a little bit better as far as accuracy, but in the grand scheme of things, you're not doing your patients a disservice if you're picking one or the other. So ultrasound, again, remember that earlier slide, they tried throwing ultrasound into the decision tree mixes, right? Along with the D-dimer and the modified wells and the CT scan, and ultrasound just doesn't add enough to sway it one way or another, right? So ultrasounding someone's leg, if you see a DVT, great, treat them. But if you don't see a DVT, that doesn't move the needle enough to obviate the need for a CT in someone who's high risk or positive with the D-dimer. All right, so this is basically a study in the Annals of Internal Medicine, just kind of putting all that together, right? So this is sort of prospectively looking at an algorithm, combining all those things that I talked about, okay? So you have the person who's low to moderate risk. You apply the modified wells, you get a likely or unlikely, use the D-dimer, yes or no with the CT, and then kind of go forward. And what they found is that this worked just fine. So people who were negative that didn't get treated, there was no adverse outcomes going forward. Okay. But remember, like, the mortality risk for PE is low, right, in someone who's hemodynamically well with no signs of any myocardial problems. So, but know that this does work. There is evidence that this works. You don't need to scan everyone to make sure they don't have a PE, as long as you're following the algorithms correctly. Okay. So this is actually one of my favorite slides. Okay. I like showing this to surgeons because I like making fun of the surgeons that they just kind of do whatever the surgeon before them told them, and they've been doing the same thing for 100 years. They're like allergic to new data. Don't tell any of them that I said that. But this is the evidence for anticoagulation in pulmonary embolisms. Okay, so this was a study of anticoagulants versus non-steroidal anti-inflammatories or placebo for the treatment of venous thromboembolism. Okay, so this is in the Lancet. Okay, in Britain in the 1950s. And so what they did is they had 11 patients diagnosed with PE. 6 of them got heparin and 5 of them didn't. Okay, the 5 people that did not get heparin all died. So they stopped the study and said, okay, everyone who has a PE needs heparin, and that was the end of it. Okay, now remember, in the 1950s, there's no CT scan, right? There's no pulmonary angiography. Okay, so the way they diagnosed these pulmonary embolisms was with a constellation of symptoms like hemoptysis, chest pain, or pre-syncope. Okay, now understandably, there's lots of criticisms about that study, to the point where they actually, a couple of decades ago, pulled the autopsy reports for these 5 deaths and found that the 5 people that died, 2 of them had pneumonia, 1 of them had biliary sepsis, 1 of them had empyema, and only 1 of them had a PE. All right. So our evidence from the 50s, why everyone gets heparin in PE, is because of this study where 80% of the people who died didn't even have the diagnosis that they were treating in the first place. All right. Now, in that PILPED study looking at history and physical comparisons, there was a subset of patients in there that actually had a missed PE on angiography. So when they read it, it was misread by the radiologist for whatever reason. And so of those 20 people, they followed them up and found that only 1 of the 20 people had died. Okay, so 95% of the people that had a missed PE on that actually did fine. Okay, so that's more evidence for, there's lots of people walking around with PEs that don't even know it. All right, the small PEs, they're there, they happen, they're not necessarily fatal, don't necessarily need treatment, but it's hard to sort those people out. Okay, so their death rate for not anticoagulating normal tensive people is about 4%, right, in 48 hours, and about 10% at 14 days is kind of what they break that down. So if you've got a PE and you're normal tensive, right, you got a 9 in 10 chance of not dying if you don't take anticoagulation, right? Now, I don't personally like those odds. So if I have a PE and I'm feeling fine, I still want my anticoagulation, right? So just because there's not great evidence for heparin doesn't mean it doesn't work, right? I mean, technically, there's no study that says that jumping out of an airplane with a parachute is a good idea, because people jump out of airplanes without parachutes and have lived, right? And no one's ever going to do that study. I would still wear a parachute when I jump out of an airplane. I would still suggest you treat PEs with anticoagulation. Just know that this is where all the evidence comes from. Okay, let's talk about anticoagulation. So heparin, right, unfractionated kind, low molecular weight kind, the warfarin, or our new novel anticoagulants. So basically, for people with acute non-massive PEs, right, so these are people that live long enough to get to the CT scanner, you get your scan, you're normal tensive, you're feeling good, you're not hypoxic, you got no evidence of any myocardial necrosis, then those people can get whatever you like, right? I like personally just putting these people on rivaroxaban. You set it and forget it. You free the pharmacist up to do other things like, transcribing medications for me instead of dealing with people coming to the hospital every day for their dalteparin and warfarin levels. Unfractionated heparin is for massive PEs. Okay, so this is the infused IV heparin, right? Use it if you're concerned about subcutaneous absorption, if people have renal disease, or if you're considering lytics for people. Okay, so the treatment is kind of, most of the time, you're going to have a normal, stable person, and you're just going to decide what kind of oral anticoagulant to put them on. If it's warfarin, you got to bridge them with heparin while they're getting therapeutic. Okay, if they're massive or submassive, we'll talk about this a little bit more in a few slides. That treatment is a little bit more nuanced, right? These people are going to get admitted. This is a conversation with your internist or whoever's running the admission, but that's kind of the decision tree, right? Admit or not admit for these things. So IVC filter is an option, okay? So you might say, well, why am I putting a filter in the IVC if the clot's already in the lungs? And it's basically just to stop other clots from getting into the lungs, right? So if you're contraindicated for anticoagulation for whatever reason, it is appropriate to do a consult for IVC filter just to prevent further clots from getting up into the lungs. Okay, a little bit on the PESI score. So PESI stands for Pulmonary Embolism Severity Index. Okay, so this is a kind of a complicated scoring system where you get assigned points for all these different variables, and then you calculate a score, and then someone who they use the score to divide people up into low, moderate, and high risk for adverse events or mortality. So basically what they found is anyone with a low risk score that got discharged and treated with an outpatient, they followed them for 90 days and no one died. Nothing bad happened. Okay. Which, I mean, sounds nice in principle, but it's not practically super useful. It's like the pneumonia severity index, right? I don't need a scoring system to tell me who's sick and needs to be admitted versus who can go home, right? Like when was the last time you saw someone with a pneumonia and needed a score to tell you whether or not they needed to be admitted or whether or not they could be treated at home, right? So, I mean, if you're struggling with it, you can use this, you can look it up, you can see, right? But the bottom line is if they look well, send them home, right? If they're hypoxic and they can't breathe, don't send them home, right? Medicine's hard, it's not that hard. Okay, so we're almost done here. I just want to go through a few cases, okay, just to kind of highlight some of the stuff here, and we'll sort of work through the management. Again, it's disappointing that we're not in the lecture hall, so I can't pick on people, but we'll see here. So, case one. Let's have a look at this girl. So 56-year-old woman with non-specific chest pain, right? So raise your hand if you've ever seen someone like this before, right? So she's got a bit of an MI history. So we're going to do some tests, okay? So vitals, not too bad, a little tacky. So EKG, not terrible. X-ray, not terrible. Blood work looks great. We do the repeats. Her troponin is magnificently normal. White count's good. Everything looks fine. So then we go in to reassess her, and she's better. So shortness of breath and chest pain have resolved. Vital signs are normal. Everything's good. Okay. So what would you do with this lady? So if you're worried that this lady has a PE, right, I would ask, why you're worried she has PE, and do you want to take her down that road? Okay. Now, unfortunately for this lady, okay, that damn PA student, well-meaning PA student, orders a D-dimer, unbeknownst to you, that comes back just a smidge above the normal range at 245. Okay, so you're getting ready to discharge her, and then boom, she's got this positive D-dimer. And now you're kind of stuck. Okay, so me personally, I have charted on a patient's chart that has a weekly positive D-dimer that I thought shouldn't have been ordered in the first place and justified away why I was ignoring it. I don't know if lots of people are going to feel comfortable doing that. Okay, but in this instance, we get this. So then we're stuck getting a scan. Okay, and lo and behold, the scan shows a small segmental PE with no evidence of RV strain in a well-appearing person. So now what are we going to do with this lady? So the consensus expert recommendation is that anyone with a CT documented PE, whether it's segmental or subsegmental, should be treated. So that's sort of their recommendation. So you get 3 months of anticoagulation, especially if it's an unprovoked PE, right? Now, there's no way that this PE that you found on this imaging had anything to do with her symptoms, but you found it now, so you're stuck treatment. Okay, so this lady gets treatment, warfarin, rivaroxaban, whatever you like. Okay, so just, you got to be real careful with that D-dimer, right? Don't order it in people where you don't really think that that's a possibility of what's going on. You're going to get stuck with results that you don't want to see. Okay, case two. So we'll have a look at this lady who's not feeling fantastic. Vitals are not great. So tacky, a little hypoxic, blood pressure's okay. So she's got an EKG that shows some inferior T-wave inversion, okay, which is non-specific, but could be a marker of some right heart strain. Chest X-ray shows an elevated hemidiaphragm. Yeah, I threw that in there. That's technically a finding on X-ray that can be associated with PE, but it's very non-specific. It's very non-sensitive. I wouldn't even worry about that. So what are we going to do with this lady? So if we were in a lecture hall and I was picking on someone, right, I would point at them and I would say, is she PERC negative? Okay. And the overwhelming response should be, who the hell cares? Because she's not really low risk, is she? Anybody look at this and think, she's probably low risk? No, this is a high risk person. Okay. I'm not ordering a D-dimer. I'm not doing a PERC score. Okay. I mean, you could do the modified wells if you want, but it's going to tell you she's high risk. So this lady needs a CT, right? We're not screwing around. We're not doing a bunch of other tests. I need to know if she's got a clot in her lung that's causing this problem. So you send her for the scan, and boom, she's got large bilateral PEs. And as she's coming back from CT, she has an unfortunate episode where she becomes syncopal, drops her blood pressure. So we put her in recess. She recovers, so she's awake now, but she's hypotensive. Heart rate's gone up. She's satting 93% on a 15-liter non-rebreathe. You got the unfractionated heparin running through the IV. So what are you going to do for this lady now? Right? So as far as the blood pressure is concerned, right? So first of all, okay, this patient is very sick. This patient should be in your recess. Okay, you should be in there with, one of the emerge docs. You guys should be on the horn with ICU. Okay, this is a sick person. Okay, you're not managing this lady in the corner by yourself. So her blood pressure being low, you can try to fix the blood pressure. All right. Fluid boluses in obstructive shock, especially with PEs, are not a great idea. Okay, because what happens is you can stretch out that right ventricle even more, okay, which is going to compromise the blood flow to it, increase the oxygen demand, and you can end up actually causing a pretty significant right ventricular infarct, okay, and then that would be game over for her, all right. Pressors are reasonable, right? There's no data to say that one pressor is better than the other. Expert consensus is that norepi is probably the pressor of choice if you want to try to bring that pressure up a little bit, okay. You can try intubating her for the saturation, but you're probably going to kill her if you do that. Okay, when you go with the induction, right, you're going to drop her preload, her pressure is going to tank, and she's going to arrest. And it's not a good idea to do CPR on someone who's running heparin, right, or especially someone you're considering giving lytics to, which is ultimately what you're going to have to do for this lady. Okay, so thrombolytics, not recommended for most PE, okay, but in sick people, if there's no relative contraindication, so you're young, your kidneys and your liver works, then go ahead and do it, okay? So studies looking at, comparing thrombolysis versus heparin for initially treating pulmonary embolisms. When you look at the massive and submassive PE categories, they found that there was definitely a difference, okay? So, 10% of people in the heparin group died 9% of the people in the thrombolytic group died versus 19% in the no thrombolytic group. Okay, so that's a number needed to treat of 10. So for every 10 people with a massive PE that you treat with lytics, you're going to save one life. All right, so massive PE, hemodynamic compromise, these people get lytics. Case 3. So here's our man who's transatlantic flight. So over that 6 hours there, he's got calf pain and swelling, worse in the morning. There are his vitals. What are we going to do with him? Okay, so this is a tricky one. Okay, so the real question is, this guy, do we think he could have a PE? Sure, right? I mean, he's got shortness of breath, he's got chest discomfort, he's got a big swollen calf. It looks like he has a DVT. So I would absolutely say that this guy, that would be on the top of my list for if he has a PE. So the PERC doesn't matter, right? Because I think he's high risk and he's over 50 anyway. If you do I guess the question is, do we order a D-dimer for this guy? Now, if you look at the modified Wells criteria, even if you thought that there's another diagnosis other than PE that's more likely for this person, he's still gonna come out in the high risk group for that, okay? So he would be over 4. His risk is technically greater than 28%. A negative D-dimer is not sufficient to exclude a guy like this from having a PE, right? So you call the radiologist, you have the fight with them, right? And they say, fine, we'll do it even though we don't have a D-dimer. D-dimer shows a large segmental PE on the left. So he comes back. The radiologist is usually going to give you an impression of the right ventricle on the CT. Because when he's looking for PE, he's also looking at that right ventricle. He will tell you if he thinks there's a sign of RV strain on the CT, right? Now, you can get a bedside echo and have a look and see if that RV is ballooned up, see if it's not contracting well enough. If he's got inverted T waves, or other EKG changes. His troponin is 221, okay, which is elevated, so he's got some myocardial necrosis. So this is a guy who's technically got a submassive P, all right? So he's got normal hemodynamics, but he's got myocardial necrosis. He's got an RV that's not happy, right? And he's on some oxygen. So, you don't need the PESI score to tell you this guy's not going home. This guy's getting admitted. He's getting treated with some kind of anticoagulant, right? And so there's the echo kind of confirming it, right? So for a guy like this guy's getting admitted. The question is, what do we do with our submassive guys? So without hypotension, but like we said, RV strain and dysfunction, right? So the echo, the troponin, all this stuff is telling you that his heart's not happy, right? There's increased mortality if there's a positive troponin with RV strain, okay? So what do we do for these guys? So this was the same study from before. And when they selected out patients that had submassive PEs, okay, so guys that, blood pressure was fine, lytics versus not lytics did not have any mortality benefit, okay? So you're not saving anyone's life pushing lytics in a case like this. Now, as we know from the stroke trials, right, lytics are not the most benign medication in the world, right? You can have complications pushing lytics, and so you shouldn't be using them in patients unless you're going to get some benefit. Now, there is growing evidence to suggest that lytics are useful in submassive PEs for morbidity reasons, because a lot of these people will end up with significant cardiovascular compromise, right? So they end up in heart failure. So, you're a healthy 40-year-old guy, and yeah, your PE doesn't kill you, but now you got an ejection fraction of 15%, and you can't walk up the stairs without getting really out of breath, right? So there is some discussion that needs to be had about the pros and cons of getting lytics to try to preserve some cardiac function. But this is not a decision that needs to happen in the emergency room, okay? This guy's getting admitted. The cardiologist and the internist are going to get together. They're going to talk to this guy. Remember, it takes time for that RV to get irreparable damage, right? So on the order of 12 to 48 hours. So there's time to make this decision. So you're not making this call in the emergency room. You're phoning medicine. You're saying, hey, I got a guy with a submassive PE. He's got a positive trope. He's got RV failure. He needs to be admitted. And then they will have the conversation in conjunction with the other specialists about if they give this guy lytics. So you can do it. But like I said, there's no rush to do that. Relatively speaking. Okay, case 4. So this lady, so I'll let you read that real quick while I have a sip of my water. So this is kind of the last resort person, right? So you got someone with big PEs and they're not doing well and they're hemodynamically compromised, and you push the lytics and they don't get better, okay? So now what do you do? So, surgical options is kind of the Hail Mary for this, right? The only place this is going to get done in the city here is at HSC, right? So if you're not at HSC and you're seeing someone with a massive PE and you give them lytics and they don't get better, while you're giving them lytics, you should be making preparations to transfer them to an ICU. If it doesn't get better, that ICU should probably be at HSC, so they have this as an option. But this is, like I said, it's a Hail Mary there. If you're in this, your mortality is really high, right? This is a sick person who's not going to do well. But this is just to make the point that they prefer trying to go in there surgically and get that clot over getting repeated thrombolytic attempts, okay? Okay, so just to wrap up here, okay? PE is a hard diagnosis to make clinically, okay? Lots of people have chest pain. Lots of people have dyspnea, okay? PE's prevalent in the community, not super prevalent, but it's there, right? So there's not really history and physical stuff that you can use to cinch your diagnosis. So you need to have a plan, all right? You got to know your decision rules. You got to know where and when to use the D-dimer, okay? Remember, scalpel, not machete. Find that patient in that right group with that right pretest probability and use your D-dimer to sway that decision. Don't just throw D-dimers at everyone with chest pain. You're going to get into trouble. Gestalt is good. Okay, your opinion matters. You have seen thousands of patients with a variety of conditions. What you think is worth something, and that is borne out in lots and lots of studies. Okay, if you think this is a heart attack, if you think this is a PE, if you think this is a pneumonia, that has weight. Okay, it's not the be all end all, but listen to your gut for that kind of stuff. Okay, You're an experienced clinician. You see people. You know what stuff looks like. What do you think? Okay, and use that as a basis for applying your rules. Heparin's the standard of care, even though there's no real evidence. But I mean, I'm not going to dispute that heparin is not good for PEs. Remember, heparin doesn't fix clots, though, right? So that heparin is not dissolving that clot in your lung. All it's doing is stabilizing it, keeping it from getting bigger, so your body can dissolve it over time, right? Thrombolytics are controversial, only recommended in massive PE. Okay, I would put the only in quotation marks there, okay, because like I said, there is growing evidence that using it in submassive PEs to preserve cardiac function is not an unreasonable thing, but it's a case-by-case basis, and it's a discussion that the internists and the cardiologists are going to have with the patient, okay? And surgical embolectomy is the last resort. So, I mean, at that point, you know, you're just hoping, right? But that's sort of the end of the line as far as management if all the other stuff isn't working. All right, so that's it. Questions? Or did I use up the time so there's no time for questions? I was trying to get it going there.
I think we have time for questions. If anybody has questions, just put your hand up, and I'll just call on everybody individually to present their question and receive an answer. I have a series of questions that I will ask at the end.
I knew you would, Barnes.
Hi, Tyler. Hi, Chris.
Lolly, how's it going?
Hi, Lolly.
It's going crazy, but it's very nice hearing you. Sorry, I had a course at the university, so I joined late. I think I missed a part, but I heard that you mentioned if patient compromise, we shouldn't proceed with CPR. Is it what you said? With PE, if we are 100.
Sorry. I didn't say you shouldn't do CPR. What I said was if someone's on thinners, right? So if you're putting someone on heparin and then you're treating someone with thrombolytics, right? Doing CPR in someone like that is going to be disastrous for bleeding reasons. So I'm not saying you shouldn't do it. I'm saying you should really try to avoid causing that patient to arrest. I mean, which obviously you should be doing all the time, but just be mindful that there's some things you can do to make this worse, right? Like inducting them for like an RSI or giving them fluid boluses when their RV can't quite handle that. So you should be trying really hard to not make this worse, because these sick people are teetering on the edge of arresting, and nobody wants to see an arresting patient that's full of TPA, right? That's just bad, right? Perfect. So assuming that patient even comes back, right, the intensivists are going to hate you.
Okay.
So don't not do Tyler. CPR. Try to avoid having to do CPR.
Yes. Okay, perfect. Thank you.
Am I off the hook?
Okay, anybody else? Okay, I'll ask questions, and if anybody else wants to interrupt me, feel free. So, okay, Tyler, you mentioned that there's a certain segment of the population that has a patent foramen ovale, which may sort of become significant when working somebody up or treating them for PE. Do you know what percentage that is? And can you just expand on that just a tiny little bit more, not too much in detail?
So the number I saw quoted was 25%, right? So if you took everyone and had like a real professional cardiac echo done, that you would see like a little bit of a gradient between that right atria and left atria in 25% of the people, right? Now, how big that gradient is, how much blood is actually going through there, it is probably variable, right? It's just that in a PE situation, because that right ventricular pressure is getting higher than the left, it means that right atria pressure is getting higher than the left. So if you have a left atria and a right atria where the right atria pressure is higher, it's going to force blood through that opening into the left side. And then you're bypassing your oxygenation system, which is your lungs. So all the supplemental oxygen in the world isn't going to help you because the blood's not going where it needs to go. So it's just like that's something that can make the hypoxia worse in someone with a PE, right? So if they've got a big, patent foraminal valley and some really high RV pressures and their SATs are 88, despite all the oxygen you're giving them, that's probably why, right? So, it's just an interesting tidbit to see, but honestly, that probably doesn't change your management at all, right? For what you're going to do for these patients. It's just something to know.
Okay, thanks. And one of your slides had noted some mortality as it relates to different types of, positive scans. One that I found interesting was 2% mortality with CT versus 1% with VQ.
So that's a mortality if you get that study, right? So like if someone rolls in an ambulance and they're hypotensive and hypoxic and looking like death, right? They're not going to the CT machine, right? So what they're saying is if you come in and you are well enough to get a CT scan as part of your diagnosis, that drops your mortality down to 2%, right? Which has nothing to do with the CT. It's just a function of how well you are at that point in time to get that imaging. Does that make sense? So It's not the scan that does it. It's just someone who's well enough to get that test, right? It's kind of like if you're doing a study, that's what they call, I forget what the type of bias that is, where someone's living long enough to get the test. So the test has nothing to do with the outcome. It's just that you lived long enough to get that, or you were clinically well enough to get that. So that's where that mortality comes out. So what you're saying is people who have low risk PEs, right, have a very lower mortality than people with massive and submassive PEs. And then the VQ is 1% just because it takes longer to arrange a VQ, right? So like by the time you arrange the VQ and send someone over there, it's just like some of those numbers might be a little fudgy, but I mean, you get the idea.
Yeah. Okay, and then next question is, have you ever come across any studies that look at what the relationship is between distal DVTs and PEs?
I mean, so not distal specific, right? So I know that that study that I showed that was kind of looking at the reliability between DVTs and PEs, right? Said that most people with DVTs, 40-50% do have some silent PEs on scan. Those are all proximal DVTs, so just DVTs that you would treat. So, like sorry, you were asking about distal DVTs?
Yeah, like below the knee.
Yeah, so I mean, like anything, like I would say that for that, I would just follow whatever the guideline is for treating that specific P, right? Or sorry, that specific DVT. I don't believe that, like, if the correlation from a proximal DVT to PE is not fantastic, right, then it's got to be even worse for a distal one, right? So I wouldn't worry, like if you're not going to anticoagulate someone because their DVT is too distal, then I wouldn't worry about a PE in that setting. I mean, that person needs a repeat scan in a couple of weeks, a repeat ultrasound in a couple of weeks to see if that thing's propagating, but I wouldn't worry about a PE with a distal DVT if you're not going to treat it.
Okay. And you talked about a couple of different scoring tools, PERC and Wells. What do you have like a go-to resource for that? Like, do you use MD Calc or do you use something else?
Yeah, I usually just type it in, and MD Calc kind of works with that, right? So, like I said, they're so well prospectively validated that they're everywhere. Like if you Google them, you're going to find something that's going to help you.
Okay. Okay. And have you ever come across any studies or specialist recommendations to evaluate the presence or absence of, say, like a submassive or massive PE using bedside ultrasound, like looking for dilated RV or pulmonary artery dilation or something, something along those lines?
Yes. So like the reality is when someone comes in, like in my case example there, I mean, that was a girl, just for simplicity, that had her scan to diagnose the PE before she kind of crumped, right? If the ambulance brings someone in who's very unwell, right? That's hypotensive, that's, tachycardic, that's hypoxic, that person's not getting a scan. So you have no real way of definitively saying this is a PE because you're not going to get a CT. So the bedside ultrasound is useful for that, right? Because if you throw that probe on someone and their RV is super dilated and hardly contracting, right? And there's no fluid around the heart to suggest a tamponade, then there's not a lot of things that are going to give you a significant RV obstruction like that other than a PE, right? So if the lungs are otherwise clear and everything else looks good, that's basically how you're trying to make that diagnosis at the bedside in the resus room, right? So yes, so that's important. It's good to get the bedside ultrasound, throw it on there, look at that RV, because that'll give you some information for what's happening. But yeah, for a lot of these massive PE patients that come through the door, you're not diagnosing them with a scan. You're diagnosing them clinically with the ultrasound because they're unwell, and then you're kind of making that decision for the lytics on faith that this is your best guess as to what's happening to this patient.
Okay, I only have two more questions. So you kind of answered the question. I wrote this question down earlier on in the presentation. You kind of answered it. I just want to make sure that I understood right. The go-to paralytic or the go-to thrombolytic is TPA versus TNK, or is there any role for TNK that you know of?
Do we even have TNK still? I don't know. I would just do the TPA, right? Because I'm sure we have a protocol for that, but that's use the TPA.
Okay. And last question from me anyways is, if we need to consult about thrombolectomy or the filter option, the IVC filter, is that through vascular?
Yes. Yeah, so I think the embolectomy might be IR, but the IVC would be vascular, right? So, but I feel like, so I think that's the answer to that question, okay? But practically speaking, right, you're not going to transfer someone direct for like an IR or a vascular that looks like that, right? So you would be sending them to that receiving site for definitive care. And then when they were there, they would decide if they're going to do that, right? So I don't think you would have to worry necessarily about setting that up. But yes, I think the embolectomy is going to be IR, but this is a sick person, right? So they're not going to sit in that IR suite and get that clot plucked out of there easily, right? The radiologists don't like doing things to people who aren't well.
All right. That's it for me.
Hey, Tyler, I have a question.
Yes, sir.
Yeah. In the emergency, it looks like most people, there's no massive PE and vital stable says it's okay to go home. So less of a choice for anticoagulation. So Eliquis, Exerotol, maybe some people think about warfarin. So what's the difference? What's your preference? I think it looks like urgent care in Victoria, it looks like the most common is rivaroxaban.
Right. So I think those medications are approved for treating PEs, right? And if you're talking about what's the best for outcome, it doesn't matter. So if you're going to send someone home on rivaroxaban, you're going to send them home on warfarin. Presuming the warfarin is therapeutic for their duration of therapy, they're going to do just as well, right? So the difference in who gets what really depends more on the patient, right? So like assuming they're healthy and they're on no medications that would be an issue and they have no allergies, it really comes down to a cost thing, right? So in a perfect world, if everything was exactly the same price, right? I don't even know why we'd have warfarin. Well, I mean, there's, I guess, some small reasons why you have warfarin, but that's the big thing, right? So the rivaroxaban, the NOACs, right? They're easy to take, right? You don't need the blood tests, right? You know they're therapeutic as long as they're taking the medication. It's just that they do cost more money, right? Now you can get, EDS approval for them, but that only helps you depending on your insurance or your deductible or your other meds, right? So like the young healthy people that aren't on any medication doesn't really matter to them, right? So this is another chat I have with pharmacy about things like that. But practically speaking, all this stuff is going to work properly. The warfarin's cheaper, but a bigger pain in the ass. So you have to have that discussion with your patient and say, hey, listen, what's going to be more annoying for you, right? Like paying, hundreds of dollars for this medicine or getting your arm poked every day for the next week and then every month for the next few months. and watching what you eat and any antibiotics and all that other stuff.
Oh, we have pharmacists here. So is a paid spa and rural road spa, which one is more expensive?
I'm just going to unmute myself here. I think they're all about relatively the same price right now.
Okay.
What I like a Pixaban a little bit better if you're worried about a bit of renal dysfunction. There's a little bit more room to dose for chronic clearance down to 15 mils per minute versus 30 for rivaroxaban. But rivaroxaban's once daily, which has its advantages also.
Okay.
I think warfarin we've not seen very often now. Most of the time it's because it's a weight issue or they're just either morbidly obese and there's no data with that. But there's a little bit more data coming out with that too now. So that's kind of where we're at.
So if some renal concern, so maybe Eliquis is better than Exarelto?
Apixaban's a little bit better for renal. It gives you just a little bit more of a window.
Yeah.
Especially in those elderly patients where you think they're going to dip down occasionally.
Okay.
Yeah.
Good, thanks.
Thank you.
Yeah, how about there's another one? Let's see the name. It's Debectran. It's good for PE or it's not good for outpatient?
You can use that one too, but it's an ugly one to do.
That's why it's cheap though.
We don't use it often anymore. You can't crush it. You can't put it in bubble packs. It's in blister packs. It's the same price too. I don't see that one used very often anymore. The newer ones are better.
Good job, Tyler.
Sorry, Tyler, I'm stealing your show.
Oh, hey, that's anytime the pharmacist can do work for me, that's a good day.
I have 2 students with me today too, so I thought it's an excellent talk for them to listen in on for sure.
All right.
Okay, that's good. All right, we've exhausted our time. So thanks, Tyler. And we'll see everybody next time. If anybody has any follow-up questions or they come up with something afterwards, feel free to email me and I'll pass them along to Dr. Stackowitz. And for the PAs and CAs out there, don't forget to send me an email for survey and you guys can get your accredited credits. That's it for now. Thanks, everybody.
Thank you.
Wonderful.
This is a virtual education series supported by the Manitoba Society of Physician Assistants. We are a not-for-profit organization that supports education and advocacy initiatives for physician assistants, clinical assistants, and other advanced providers throughout Manitoba. You can visit us at www.msofpa.ca. Don't forget to subscribe to our newsletter and follow us on Instagram, Twitter, and Facebook. Thank you for listening, and thanks for watching.